Good day and welcome to this webinar on fibrous dysplasia of bone, McCune Albright syndrome, an update. My name is Dominique Pierrot. I'm the science manager at IOF and I'm delighted to moderate today's webinar. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speakers toward the end of the webinar. This being said, I have the great pleasure today to welcome Professor Roland Chapurla. Dr. Chapurla is Professor of Rheumatology and Head of the Rheumatology and Bone Pathology Division at Édouard Herriot Hospital in Lyon, and he is the director of a unit of the National Institute of Health and Medical Research in Serum at the University of Lyon in France. Professor Chapurla is a member of the European Reference Network on rare bone diseases and has been a member of the IOF Committee of Scientific Advisors for more than a decade. He has published over 350 publications in peer-reviewed journals on osteoporosis, osteoarthritis, and rare bone diseases, including fibrous dysplasia with McCune Albright syndrome and osteogenesis imperfecta. Professor Chapurla, thanks again for having agreed to speak today. We are delighted to have you with us, and we are listening to your presentation.
Thank you very much for this nice introduction. And first, I want to show you the usual disclosure slide. And we are talking about a rare disease, but there's a lot of publications and scientific activity in this field. And as you can see, there were many papers that were published in FDMAS just in 2021, and it's continuing. So there's a lot of clinical research, but also a lot of basic research. And so we have very interesting perspectives in terms of understanding the pathophysiology and, more importantly, developing drugs in the future. So what I would like to do today is to give you a clinical approach of this topic, as well as a number of treatment perspectives. So first of all, I would like to make a brief statement on the nosology of the disease, because in rare diseases, you often have the name of those who have described the disease, and there are often several names of the disease. And so at the FDMAS consortium, which is an international consortium working on this disease, we have agreed to change a little bit the name of the disease, so that now it's fibrous dysplasia of bone / McCune Albright syndrome, because it's the same disease. It's a wide spectrum. So a lot of patients, the majority of patients, have a relatively benign disease involving only one bone. And at the other extremity of the spectrum, the patients have a lot of bone that are involved, the polycytic disease, plus often endocrine complications. And this is the true McCune Albright syndrome. So if you look at this table, you can see that if the patient has one bone that's affected, that's monocytic FD. If there are several bones, at least two, that are involved, this is polyostotic. And the real McCune Albright syndrome, that's one or several, more often several bones that are affected, plus the café spots, plus endocrine disease. And the most often, this is the precocious puberty, the peripheral precocious puberty. And Mantle-Brough syndrome is fibrous dysplasia of bone plus muscle involvement, myxomas, benign myxomas. So what about the pathophysiology? This disease is due to a mutation of GNAS, leading to an accumulation, an increase, I should say, of intracellular AMP, cyclic AMP, and this leads to a C-FOS overexpression and an issue in terms of the differentiation of osteoblasts. So we have abnormally differentiated osteoblasts, or I should say osteoblastic cells, because they are really poorly differentiated. So this is basically a disease of the stem cells. And these mutated cells produce a number of cytokines or factors in excess that are at the origin of a number of the characteristics we observe in terms of histology or even in clinics. And one of these important factors is, of course, rank ligand. So there's an overexpression production of rank ligand in the cells, and has been published in recent years, in particular from the group of Rome, and so this leads to an increased bone resorption. IL-6 also is expressed in excess, and this can also increase the bone resorption, and this IL-6 can be also produced in an autocrine manner by osteoclast. And the increased bone resorption may be aggravated by increased serum PTH if there is secondary hyperparathyroidism due to, for example, vitamin D deficiency. PDGF beta has also been shown to be produced in excess in some studies, and so this leads to the resorption of normal bone surrounding the fibrous tissue that's produced by the mutated cells. And so this leads to bone deformity, probably, and certainly the osteolytic lesions leading to bone fragility and fracture. These mutated cells also produce an excess of FGF23 that leads to renal phosphate wasting, and this is clinically observable in those who have a relatively large extension of disease, so those patients who have polycystic fibrous dysplasia. Probably half of the patients who have polycystic fibrous dysplasia also have renal phosphate wasting due to increased FGF23. This is quite comparable to what we observe with tumor-induced osteomalacia, in fact. And so here you can see that you have a number of manifestations or a number of cytokine factors that are produced that maybe we can target with treatments. So what I would like to talk about is, of course, a number of important aspects in terms of diagnosis, what could be the markers of disease, pain and quality of life, the complications of the disease, and also the potential therapies. So pain is the leading symptoms. Probably half of the patient at some point in their life will have bone pain. This can be resting bone pain or mechanical bone pain elicited by movement, by walking, for example. And some patients undergo fracture, endocrinopathy, and the most frequent, once again, is precocious puberty, bone deformity, and about a quarter of the patients actually don't have symptoms, and the diagnosis is incidental. So they benefit from imaging for any reason, and the bone diseases is discovered this way. So of course, the most simple way to make the diagnosis is the plain X-ray, and so there are different aspects on the plain X-rays, but the most important is certainly the so-called ground glass appearance that you can see on the left-hand panel, and the B panel is certainly the most obvious. CT scan is also very important, and it can show again demonstrates the ground glass appearance, but also osteolytic lesions, the cortical thinning, stress fractures when the fracture are not visible on the plain X-ray. MRI may be interesting in terms of differential diagnosis compared with bone size, for example, and it's important also to explore neurologic complications, nerve root compressions, for example. And you can see at the bottom of the slide also a typical Caffarelli spot. Bone scintigraphy that you can see on the panel D is very important to explore the extension of the disease, and it should be performed at least once to have a complete map of the lesion in a given patient. And so this is a sort of a theoretical classifications of the different lesions in terms of the radiographic appearance based on the degree of bone expansion. So the type 1 is a simple lesion, and that's born in the trabecular bone, and this is a very important diagnostic criteria. The fibrous dysplasia is born from the medulla, from the trabecular bone, and it may be surrounded by a dense bone. That's sort of a signature of a benign lesion, but also is very characteristic of FD. And if the lesion is growing, then it can be classified as a type 2. Often there's thinning of the cortex, and type 3 is a bigger lesion with a cortex that's even thinner or even interrupted in some areas. And so this bone is very fragile. This is an example on the left-hand side of actually a differential diagnosis. This is probably a bone site that you are seeing, but because there's not that much of granulous appearance on this CT scan. On the middle of the slide, this is a typical CT scan of a ethmoidal involvement by FD. And on the right-hand side, you will see lesions, typical lesions with the expansion of the bone, granulous appearance in the radius, and also the tibia and fibula. This technology is very interesting, in particular in children. This is a system, EOS, that allows to get a radiograph of the entire body in 3 dimensions. And so this is quite interesting in those young children in whom it's probably too early to do a bone scintigraphy, a technetium-99 bone scintigraphy, because they can move a lot. And so the radiation dose of this equipment is probably 5 to 7 times lower than conventional radiograph. And so if we want to repeat the radiograph to monitor the patients, that's also very attractive. In our cohort, and in this analysis, we have analyzed 372 patients. We observed a number of endocrine complications. Most of them were precocious puberty, so increase in estrogen. In 90% of patients, these are girls, and 10% are boys. So increase in peripheral hormones, but not no increase in LH-RH, at least at the beginning of the disease, and much more rarely we could observe a hyperthyroidism, Cushing syndrome, or growth hormone excess, and also hyperprolactinemia. And even in adults, it's critical to look for endocrine complications, including mainly hyperthyroidism and growth hormone index excess in those patients who have craniofacial involvement, even if they did not have precocious puberty earlier, because there's a number of patients who may develop these complications, probably because they have a number of mutated cells that are present in their pituitary gland. So once again, it's critical to obtain a map of all lesions, and this can be obtained in children after age 8-10, when they are when it becomes feasible to do the bone scintigraphy, or in adults if the diagnosis is made in an adult. So on the left-hand side, you'll see a technetium-99 scintigraphy. On the right-hand side, this is a fluoride PET scan, PET CT. This is not the same patients, and so the uptake of sodium fluoride is probably greater than that of technetium-99, but both techniques can be used. Of course, bone scintigraphy, the traditional bone scintigraphy, is more widely available and less expensive. Biochemical markers have been used for decades to evaluate the level of bone turnover in those patients. So the most traditional and most widely used is, of course, total alkaline phosphatase. That often gives a good picture of the level of bone turnover in those patients who have polycystic fibrous dysplasia. Markers of bone resorption like CTX can also be used. And more recently, other markers have been looked at, and in particular, we have made a study looking at the value of serum periostin, which is a marker that's produced mainly by the periosteum that's been associated with fracture in osteoporotic women and also with severity of osteoarthritis at the knee. And so we looked at the serum concentration of periostin, and we found that the polycystic patients had increased concentrations, and so this may be of interest in the monitoring in the future. MicroRNAs, which are non-coding RNAs that are very well conserved across species and also very robust in terms of conservation in serum samples, can be also measured, and we found that a number of them are upregulated, and they could also become markers in this disease, but this is still research at an early stage. Pain. I must say that many patients don't have bone pain. Probably a third or half of the patients never experience pain. And the pain intensity tends to increase with age. And so bone pain may reveal the disease in young adults or in adults in their 40s, and we commonly observe this in our consultations. There is no association with the number of affected sites, and so we may have patients who have monostatic FD with bone pain and polystatic patients who don't have bone pain. There is no association with bone turnover, and some of the patients with really high bone turnover, really high alkaline phosphatase, don't have bone pain. And so this can be nociceptive pain, but it can also have neuropathic characteristics. And one of the main question marks in this disease is the mechanism of bone pain. And there's still a lot of research to do on that to understand it and then to be able to treat it more efficiently. I would like to make a special mention for headache, because headache can be a signal for a serious complication. And so this is an example of a case report we made several years ago. This was a young patient, 18 or 19 years old, who never had bone pain before. FD was known, and but not treated because there was no indication. And then he suddenly developed very violent headache that was related to intracranial hypertension, related to a bone site that had developed. And you can see here the liquid level on the MRI on the right-hand side. That led to a compression of the sigmoid vein and a thrombosis that needed to be stented. So this was a quite emergent situation. So what I would like to suggest or even recommend is that in those patients who have an increase in their usual headache, or if they develop headache whereas they were not painful before, we should do an MRI quite rapidly to identify these kind of complications. What about the quality of life? So this is a very important metrics, of course, and this is a study from the Netherlands looking at a series of 97 patients. 2/3 had monostatic, 27% polystatic, 9% McCune Albright syndrome. So this is the usual distribution of the lesions. In general, 2/3 of patients have monostatic disease, 1/3 have polyastatic disease. And so they look at the usual and a generic metrics in quality of life, that is the SF-36 scale, and this is using the brief pain inventory. And so you can see that the quality of life of those who have fibrous dysplasia was a bit reduced compared to the general Dutch population. and particularly for role physical and bodily pain and general health, and also vitality and social function, but no reduction in mental health or role emotional. And then if you look at the different clinical forms of the disease, the monostatic patients had almost no difference compared with the general population, whereas the polyostatic patients had really reduced quality of life, in particular role physical, pain, general health, vitality, social function. And this was even more pronounced for those who had McCune Albright syndrome, so the endocrine complications. But again, no impairment in mental health and role emotional. Tumors. So these are, of course, among the most important complications. So breast cancer, this has been identified in a cohort study with data from the Netherlands and the US. And they found that there was an increase in the risk of breast cancer, in particular in those patients who had McCune Albright syndrome, so a longer exposition to estrogen in the lifetime. Those who had rib involvement, as well as polyostatic disease. And so probably we have to start screening and monitoring for breast cancer earlier than in other women, probably in women starting at age 35 or 40 rather than age 50, like it's recommended for a woman without FT. Thyroid cancer may also be encountered, in particular in those who have McCune Albright syndrome. Pancreatic tumors, and these are mucinous tumors, may be encountered in those who have polyostatic fibrous dysplasia. So clearly, we have to image the pancreas using MRI in those patients who have polyostatic fibrous dysplasia. And then if we found those tumors, we have to monitor that probably on a yearly basis. Liver tumors are generally benign tumors, adenomas, but we have to monitor that and look for them, and especially in those who have McCune Albright and polyostatic disease. And osteosarcoma is a complication of the bone lesions, even in monostatic patients. There are risk factors for that, so this is radiation therapy that should be avoided, and also growth hormone axis. And so this is a rare complication. It's difficult to really define the incidence, but probably 0.5 to 1% of the patients may have osteosarcoma or chondrosarcoma or fibrosarcoma. So those patients who have unusual pain, in particular on an inflammatory mode or elevation of C-reactive protein, should be explored using imaging. Another complication is the optic nerve compression in those who have craniofacial involvement. And so here we have to monitor the patients, essentially using visual field, repeated visual field measurements, as well as OCT, optic coherence tomography measurements, twice a year or yearly, depending on the severity and the age. We must remember that something like 95% of the patients will never become blind, fortunately, which also is a justification to avoid systematic preventive surgery. And so surgery is warranted in those patients who have an aggravation of the optic nerve compression that's objectified on the OCT measurements, for example. But certainly not preventive, because we know that probably around 30% of the patients may undergo aggravation after surgery. Fracture is probably the most common complication. And so in our cohort of 376 patients, we look at the predictors of the risk of fracture. And we found that the form of FD was the main predictor. So polyostatic patients have more fracture. Age diagnosis also, so the younger the diagnosis is made, the higher the risk. And also the prevalent fracture is a predictor, and renal phosphate wasting is also a predictor. And so here in this study from the NIH, you can see that this is a direct comparison of patients who had renal phosphate wasting versus the others, and you can see that the incidence of fracture was much higher, in particular in young patients. So this is an argument to try to correct the hypophosphatemia and leading to mineralization defects using phosphate plus calcitriol. The mutated cells are probably very fragile, and they need to be sort of surrounded and cooperate with a normal bone environment and normal bone cells. And so with aging, it's been described that the number of mutated cells is decreasing progressively. And here in this analysis, you can see that also Serum FGF23 and rank ligand are declining with age. So turning to therapies, the most widely used treatment nowadays for the treatment of precocious puberty is letrozole, because this is an aromatase inhibitor that will inhibit the production of estrogen by the ovaries. And so, and in general, this will stop the evolution of precocious puberty and allow for a better growth. Surgery, maybe preventive surgery or curative surgery if there's a fracture, and I will get into detail later on. Calcium and vitamin D is a sort of a prerequisite in those patients, because we want to limit the risk of osteomalacia and secondary hypopara that's sort of aggravating the basic lesions. So phosphorus, calcitriol are important in those who have renal phosphate wasting. And bone pain has been treated by bisphosphonates for decades, and we'll also get into greater detail. So surgery is often necessary to prevent fracture, and so this is an internal fixation. And in children, we should use devices like those ones. So essentially, telescopic nails that adapt to the bone growth. And in adults, it may also be important to treat deformities. And one of the most important lesions is certainly the varus deformity. That's an important factor in the risk of hip fracture in those patients. And but the type of surgery is certainly nailing, once again, because plates and warts may lead to fracture due to stress shielding. So probably the approach that's to be favored is certainly the one that's presented on the left-hand side. So turning to medical treatments and bisphosphonates to start with. So we've been using bisphosphonates for probably the end of the 1980s. And at that time, the most potent bisphosphonate was IV Pamidronate, that was used also as the treatment of Paget's disease of bone. And so we used the same type of approach and same type of doses with courses of 180 milligrams. And we observed that there was an association with a decrease in the osteolytic lesions and also in bone pain. Again, regarding surgery, the treatment of scoliosis have often been overlooked. And I believe that those children with FD should be monitored for scoliosis because it may lead to a complication and also back pain later in adults. Craniofacial surgery, again, is a difficult one, and so it shouldn't be systematic in those patients who have nerve compression, in particular the optic nerve compression, because there's a high rate of complications. And so this should be considered in those who have a proven aggravation. But plastic surgery for those who have craniofacial deformity is very useful and with very good outcomes. Aneurysmal cyst may also be a good indication, and of course, for those who have the pancreatic tumors, which are IPMNs types of tumors, this is a very good indication. So we've taken a look at the approaches to try to decrease the risk of fracture using essentially surgery and also maybe anti-resorptive agents. But the main indication of anti-resorptive agents like Pamidronate or other bisphosphonates maybe is its role on bone pain and to decrease bone pain. And so this is one of analysis, and there are several analyses of this type, showing that there's a substantial decrease in bone pain after repeated infusions of Pamidronate. And most patients are responders. And there's no relationship with potential radiographic response, by the way. And there's also no relationship with the effect on markers. And so if patients have a decline in their bone markers, it doesn't mean that they will have a decrease in bone pain and vice versa. So this is quite strange in terms of the understanding of the way the patient reacts to bisphosphonates and bone pain. One way to treat more easily those patients could be to use oral bisphosphonates. And actually, there are two randomized trials, placebo-controlled randomized trial. And so this is a trial using Alendronate. And so they used the dose to treat the patchitis of bone, 40 milligram, 6 months on, 6 months on, 6 months off, and this was repeated for 2 years. And so if you look at this main pain score, you can see that there's absolutely no difference between the Alendronate group and the placebo group. One can argue that the mean baseline value of bone pain was low, around 3 on a scale of 10. And there's another trial that we have conducted using another bisphosphonate, that is Resedronate. And here we had enrolled patients based on their baseline bone pain that was around 5.5 at the baseline. But you can see that there was, again, no difference in terms of when in comparison with placebo. So clearly, we shouldn't use oral bisphosphonate, probably because they are not potent enough, and turn to IV bisphosphonates like Pamidronate or Alendronate. And so Alendronate, we have used this more potent bisphosphonate in patients who are resisting or relapsing on Pamidronate, and we found that there was a decline, an additional effect in terms of bone pain, but that was not very substantial. And here the mode of administration was 4 milligrams every 6 months. So to sort of summarize the different steps of the management, first of all, we have to establish a diagnosis. In some patients, it's very easy because there are several lesions. And so if there's a typical distribution on one side of the body with the ground glass appearance, with an expansion of a number of bones, the simple X-rays may be sufficient. In some other patients, when the lesion is metastatic or the radiographic appearance is not typical, we may need a bone biopsy. We try to do few biopsies as possible because there might be complications, but still it's sometimes necessary. And then it's very important to do the molecular biology to look for a GNAS mutation, because often there's a fibrous aspect that's difficult to distinguish from other types of bone lesions, of bone tumors. And so it's very important to obtain the analysis of the mutation. And then we have to assess, when the diagnosis has been established, we have to assess the extension and severity of the disease, so a bone scan to have a complete map of the skeleton. radiograph, including the EOS technique when it's available, because there's less irradiation, and so it's very convenient to monitor patients and repeat the radiographs. And biochemical markers of bone turnover are also useful in monitoring of treatment with bisphosphonates, for example. And then we have to treat the associated conditions, so precocious puberty or other endocrine complications. So, for example, GS, growth hormone excess, will be treated with pegmesomant. In general, the treatment is a medical treatment because it's difficult to do surgery in those who have craniofacial involvement, to do pituitary surgery. Renal phosphate wasting is a good indication to provide with phosphate and gas trial. And then we have a number of perspectives, because not all patients are responding to IV bisphosphonates, or they may relapse on IV bisphosphonates. We've seen that rank ligand is a major cytokine involved in the pathophysiology of the disease. And so it's natural to try to use an anti-rank ligand drug like Denosumab. So this is a case report of a patient that was treated with a lot of Pamidronate and then zoledronic acid, and who did not really respond well. And after a single injection of the 60 milligram of Denosumab, there was a very good response in terms of bone pain, and of course a decline in bone resorption. But then the bone pain relapsed, and it was difficult to control. And it was possible only using opioids. So mixed result in this case, but there are other observations or small case series showing somewhat interesting results in some patients. This is a very important case report, I believe. So here, in this patient, the Denosumab was used at higher doses, and this was a really severe disease that was evolving, and that was very painful. And the patient got a very significant improvement in terms of clinical outcomes. And you can also observe that there was a densification of the lesion in response to therapy. However, when the patient stopped Denosumab, there was a massive rebound in bone remodeling. That's well known in those patients with postmenopausal osteoporosis when we stop the therapy. But here the rebound was much more important, and actually led to a severe hypoglycemia that was very difficult to control using IV bisphosphonates. So there are other observations of the difficulties to use Denosumab in children, and with and other cases of hypoglycemia. And so clearly we should not use Denosumab outside this setting of clinical trials in children, because of this issue of rebound of turnover, as well as the risk of hyperglycemia. But anyway, this is an argument to say that there may be sort of a disease-modifying effect of Denosumab. And in this mice study from Italy, from the group of Rome, which has worked a lot on this topic, they have a mice model of fibrous dysplasia, and they looked at the effect of zoledronic acid and the effect of an inhibitor of rank ligand. This is not Denosumab, because the rank ligand in mice is different, but this is an inhibitor. And so on top you can see the control group. Well, there's no improvement. There's a trend toward an improvement with zoledronic acid, and at the bottom of the slide you can see that there's a real intensification, reduction in osteolysis when rank ligand is inhibited. So it looks like as if the disease were improved. And that's interesting, because we are targeting the osteoclast, whereas this is a disease of the osteoblastic lineage. On the right-hand side, you can see the BVTV in those effective bones, and these are tail bone actually. And you can see there's a significant improvement in BVTV using ZOL, but much more important by inhibition of rank ligand. So this is clearly a clue on new approaches for therapies. But again, in young patients, we cannot inhibit rank ligand because of the risk of hypercalcemia if this treatment is stopped. So maybe we should treat only adults, but clearly, again, we need clinical trials, randomized trials, to establish that there's a benefit in terms of improving the histology, so that this can be a disease-modifying drug, and that it can also improve the bone pain compared with the placebo. Denosumab withdrawal has also been studied in adults, and you can see that as expected, there's a rebound that may be less important than in postmenopausal osteoporosis, but these patients have been pretreated with bisphosphonate, so this may be a sort of protection. I've shown you that IL-6 is very important. The increase in IL-6 is very important in the pathophysiology of the disease. So we have conducted a randomized trial to inhibit the IL-6 pathway using tocilizumab, which is a monoclonal antibody to the receptor of IL-6. And so this was a crossover design. So the patient received tocilizumab IV monthly for 6 months and then placebo, or vice versa. The primary outcome was the change in serum CTX, and this was quite disappointing because you can see here that there was absolutely no difference between the treatment sequences, and so tocilizumab did not reduce CTX, and it did not reduce any of the other markers that we tested, including P1NP, alkaline phosphatase, well, bone alkaline phosphatase, or ICTP. And if you look at the change in bone pain, and these are the individual trajectories, you can see that a number of patients had sharp decrease in bone pain while on tocilizumab and relapse while on placebo, but this is only a limited number, and so there was no significant difference between the sequences of the treatment. But maybe there's an effect of the inhibition of IL-6 in a subset of patients, but again, we don't really understand the pathophysiology of bone pain in this disease, and so it's difficult to identify this subset. I can recommend those who are interested to read this paper, because we've made a thorough evaluation of the literature, and so we propose sort of a framework to manage the patients with fibrous dysplasia, McCune Albright syndrome, in terms of diagnostic approaches as well as treatment. So it's quite simple and quite complete, both for the treatment of the bone disease as well as the complications. So to conclude, I would say that we need a thorough assessment of the disease extension at the very beginning, of the severity, and so we have to make a complete evaluation in terms of imaging and also the endocrine complications, or to look for the tumoral complications, and of course to look for renal phosphate wasting. So monitoring of hormones, phosphate, visual parameters. In those patients who have bone pain, IV bisphosphonates is the mainstay of therapy. And fortunately, we have a number of perspectives. Biologic treatments, maybe denosumab. We need to conduct good randomized trials, but this is a fairly reasonable perspective. Maybe targeted agents, and so at the beginning in the slide regarding pathophysiology, I mentioned the role of PGF-beta. There's not yet published data, but this year at the SBMR there was an interesting presentation by a group from Geneva, Switzerland, showing that the inhibition of this pathway could lead to improvement in the histology of the disease. So we have a number of interesting targets to treat those patients in the future. So finally, I want to acknowledge all the groups who work on the disease, who have made a great job of conducting the monitoring a big cohort. It's very useful for research and the clinical trials we have conducted. And thank you very much for your attention. I hope we have a number of questions.
Thank you very much, Professor Shapurla, for this very comprehensive presentation. It was greatly appreciated by our audience, and many participants are thanking you for a great talk in the question box. Can you maybe just come back one slide, because we'll go to the Q&A exactly. So maybe I will start with a question by Dr. Badurski, who is asking if a patient with FD does not have any symptom, should it be treated or not?
It depends. If it's a monostatic form, I would certainly no bone pain, or a polystatic form and no bone pain. Certainly I would monitor, but I would not give systematically bisphosphonates. I believe the main indication, if not the sole indication of bisphosphonates in this disease is to treat bone pain. And then if this polystatic patient has renal phosphate wasting, certainly the use of phosphate and calcitriol is a valuable approach to try to minimize the mineralization defect and so the risk of fracture. And if there's craniofacial involvement, or if there was precocious puberty earlier, it's very important to monitor the hormone to be able to treat growth hormone excess in particular as early as possible. So the treatment with bisphosphonate is not systematic.
Thank you. There is a question from Dr. Pop. He's asking if FGF23 is a potential marker to monitor the disease activity or treatment.
Yeah, very good questions. The increase of FGF23 is much lesser than what we see in X-linked hypophosphatemia or in tumor-induced osteomalacia. And so we are just above the upper limit of normal range often. And so it's not a good marker to monitor that. So we monitor looking at phosphatemia simply. And and also, well, this is the opportunity to mention the inhibition of FGF23. You know that Denosumab is an antibody against FGF23 that's now used quite a lot in the treatment of XLH, X-linked hypophosphatemia. And there is also a possible use in TIO, tumor-induced osteomalacia. So there's a rationale to use that in those patients who have overt osteomalacia in FD. There's a small study that's starting in the US, but we don't have yet data. And so, but this is a possibility in those patients who developed, for example, kidney failure or nephrocalcinosis while being on long-term calcitriol and phosphate. And so in the future, it's not yet the case, but in the future, Denosumab may be indicated in those severe patients with FD.
Thank you. There is a question from Dr. Khan, who is asking if you can clarify again the reason for not using Prolia in children.
So two reasons, I believe. One that I've mentioned, that is when you stop the disease, the Denosumab, when you stop Denosumab, there's a massive increase in bone turnover. That's much more important than adults, by the way. And so these patients are at risk, or actually they developed hypercalcemia. That's very difficult to treat using zoledronic acid. So I believe this is so you cannot stop the drug. The other reason why is that rank ligand is important in the development of immunity, in particular at the level of the thymus. And so inhibiting Denosumab in young children may have immune implications. And so this is, I believe, two very good reasons not to use bisphosphonates in the growing skeleton and in children in general.
Thank you. There is a question from Dr. Orr. He's asking if there is a role for local application of bone cement with zoledronic acid in case of surgery for pain or fracture?
We've never done that. Actually, we wouldn't really know what we're doing in the long term, because if these patients years later or decades later developed a bone sarcoma, the presence of cement may be a difficulty if you want to do surgery. Also, there's no available convincing study showing that we have a benefit in terms of bone strength. So I would like to avoid that. We don't have evidence that it's useful.
Thank you. There is a question from Dr. Bardowski asking what do you think if it's important to continue treatment of a patient who has been under bisphosphonate for many years, for example, if there are no changes in the bone and no pain, but an endocrinopathy?
Yes, we try to stop bisphosphonate therapy after 2 or 3 years, because we are often treating young patients, and we know that cumulative doses of bisphosphonate, or IV high dose bisphosphonate, expose those patients to complications like osteonecrosis of the jaw and atypical fractures. And so after 2 or 3 years, if we have a very good response in terms of bone pain, we try to stop. It's not always possible, but at least we try. And well, I'm not sure there's a relationship with the presence or not of an endocrinopathy. And so, again, the main indication is bone pain. I'm also not convinced that there's a significant improvement in bone strength, actually. From our earlier studies using X-rays, we found that there was an improvement in osteolytic lesions. So there may be some improvement, but is it substantial? We don't know. We've never been able to show that there would be a reduction in the risk of fracture. From the recent mice studies, we see that there's a small improvement, but the consequences in terms of bone strength are quite uncertain, I would say.
Okay. We have many questions about treatment, bisphosphonate and denosumab. This question from Dr. Valadares. She's asking if you would recommend denosumab for patients with bone pain refractory to zoledronate, and how long and which dose will you consider it?
So we are doing that from time to time, and so there are different approaches. In our group, when we do that, we use denosumab 120 milligrams every 3 months, and we try to taper depending on the results after 6 or to 12 months. Other groups use lower doses, and for example, in the Netherlands, they do 60 milligrams every 3 months, and then they try to taper depending on the results. And so currently we have few data. We are doing that off-label and collecting the data on an observational matter. There will probably a randomized trial placebo-controlled randomized trial testing the effect on bone pain in the coming years, and so we will see whether our initial attitude was justified. So currently the level of evidence is pretty low, but it happens that we do that. But again, if the drug has to be stopped, certainly doing 1 or 2 infusions of zoledronic acid afterwards is probably warranted, because to try to mitigate the bone turnover rebound, or I should say overshoot, to avoid complications that may be fractures.
Thank you. There is another question from Dr. Khan, now related to the disease-modifying drug. She's just asking you, it seems that there are none for the moment based on your presentation. Yes. So is bisphosphonate the only treatment for pain?
At this point, we can use the usual painkillers, NSAIDs, and bisphosphonates, yes.
Okay. So people are thanking you for your detailed answers also on the chat. And yeah, there is another question about the zoledronic acid, the dose, but you have already responded, I think. So I think there is no more question, and I think it's time to conclude. So I really would like to thank all our participants to this webinar, and we hope that you enjoyed this session. We will post the recording of the webinar on the IOF website, and you will receive your certificate of attendance and the link to the recording by email tomorrow in 24 hours, like tomorrow, end of the day for the European people. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments. And if you have any questions, comments, please do not hesitate to send them at the address webinar@osteoporosis.foundation. Thank you again, Professor Shapurla. That was a great talk. And yeah, a nice discussion, many interesting questions about the treatment, especially. And goodbye to everyone.
Bye-bye.